Hello, my name is Carolina Pavlovsky. I'm from Buenos Aires, Argentina, and I'm going to talk today about CML and the main laboratory studies and diagnosis. This is a little bit of my country, Argentina, and where it is, with the place and the pictures of the north and south. And this is a little bit about my institution, FUNDALEU, and the three important buildings. So we start with CML at the present time. And with the widespread availability of the good quality of TKI with this treatment in the developed world, we all know that the survival of patients with CML in chronic phase has approached the general population. However, the situation in middle and low-income countries is not so promising. And there are several factors that influence CML outcome and TKI selection, as disease characteristics, the patient age, comorbidities, the treatment objectives and preferences, and the TKI profile of the adverse events, as we all know. But to this, we have to add the low-income countries' problems, as the lack of treatment options since first line, of the drug cost, the drug availability issues, the branded and non-branded differences of the TKI, and that some patients do not have a continuous access to high-quality PCR/ABL testing in different parts of the world. Baseline studies about CML diagnosis are the one as follows, and these are included in the Argentine Society of Hematology CML guidelines, and are the one described below as the physical examination with the measurement of the spleen, a complete blood count, bone marrow aspirate, an important cytogenetic in a well-done laboratory, binding analysis, the FISH in case Phi negative to identify cryptic translocations, and then the molecular analysis that could be the qualitative reverse PCR or optionally the quantitative PCR. Also, an ICG and a standard biochemical profile with the hepatitis serology must be done. It's recommended. So the CML method sensitivity you can see here are the cytogenetics, the FISH, and the RQ-PCR. In the cytogenetic one, the target chromosome is a Philadelphia chromosome, and we all know that it has to be done in the bone marrow. The sensitivity goes from 1 to 10%, and the other study, as the FISH, has a target. The target is the BCR-ABL juxtaposition gene. One of the facilities is that it can be done in peripheral blood. And then we have the PCR, the qPCR, that also can be done in peripheral blood. And this is the most sensitive method for monitoring patients. The first step for diagnosis is the cytogenetics. Here you can see the karyotype, the chromosome 22, and the chromosome 9 and the Phi chromosome, where you can see that it's very important to detect the Phi chromosome at diagnosis in bone marrow. And this should always be done at diagnosis to confirm the presence of the Phi chromosome and also additional chromosomal abnormalities. If we have the Phi chromosome plus the chromosomal abnormalities, this is talking about as a worse prognosis. There are high-risk chromosomal abnormalities, as you can see below, as isochromosome 17, trisomy 8 and 17, 19, and the ones you see below, and these are of high risk. Most of the CML cases exhibit the Phi chromosome or a variant on conventional cytogenetic analysis. Remaining cases with cryptic BCR-ABL fusion may be detected by FISH or reverse transcript PCR. Most of the CML patients, 97%, express a chimeric RNA in which BCR exon 13 or exon 14 joins ABL exon 2. There are very little cases where they express a typical RNA fusion involving other exons of BCR or ABL. So it's very important to determine the transcript type prior to treatment to enable the molecular monitoring and effective molecular monitoring when we are measuring response in a TKI treatment patient. So here we can see the survival comparison in patients with chromosomal abnormalities detected at CML diagnosis. And we can see the overall survival in the group of worst prognosis, that is the one in yellow that has chromosomal abnormalities of high risk compared to the one with a better prognosis, which is the group 1. So it's very important to know if the patient has a chromosomal abnormality diagnosis, because the prognosis changes. So if standardized qPCR is available, what would be the role of the cytogenetic analysis? Is this essential? If we have a good PCR, perhaps cytogenetic analysis is not as essential as it was some years ago. Clonal evolution, however, rarely occurs without increasing transcript concentration and probably inducing a loss of hematological response. So if we have these two signs of transcript rising or an hematological loss response, that the patient loses hematological response, we must perform a cytogenetic analysis. Also, if we see patients that are having anemia or thrombocytopenia, this is an important sign to make a cytogenetic during follow-up. Important analysis or test that I must mention is the FISH that can be in peripheral blood, as I have said. And this technique, the technique has not been validated for cytogenetic response assessment, as we know, but most experts consider it adequate for this purpose. So many experts are using, many doctors are using it in replacement to the cytogenetic, or when with the cytogenetic cannot be done. But it's important to take into account that FISH cannot identify additional chromosomal abnormalities, and it is not as sensitive as a PCR. We cannot compare each one to another. It can be valuable in the case of patients with a typical transcript, and it's very important to consider that never, but never, we must use FISH to follow up a patient that is in TFR, or to make decisions in patients that are planning TFR. FISH is not for that. And what about the molecular methods? So the PCR, the quantitative PCR, a diagnosis, is a critical tool for monitoring disease burden. During the course of the disease and at the specific time points, this is important to make because it would help us to take and to consider some decisions regarding the TKI treatment. It provides an accurate measurement of the total leukemia cell mass and the degree to which the P210, the P210 BCR-ABL transcript are reduced by therapy. So if we have a patient that we have a PCR, a diagnosis, and it lowers the transcript at month 3, this is a very important sign. We can calculate the halving time, and we know that this correlates with PFS. And this is the most precise method to monitor CML patients and unique for TFR patients. But we all know that there is another PCR, that it's the qualitative PCR, and this also is important to be considered when the patients are diagnosed, because it gives another information, different information. This is qualitative. It's going to inform us if it's positive, is it present or not, the transcript, and it's recommended a diagnosis to perform and detect the type of transcript, B2A2, B3A2, and some other variants. So it's important to name the international scale as a measurement or as a technique that has have improved the monitoring around the world. And every laboratory and every lab must be international, it must be standardized. This is not always possible. And in low-income countries, this is very difficult. So some centers continue to use their established systems for BCR, ABL, and convert results to the international scale using a conversion factor derived by sample exchange or by the use of calibrated reference agents. All laboratories that are approved and that are standardized should be accredited, participate in appropriate internal and external quality assurance schemes, and ensure that their assay is optimized to detect disease at a level of 4.5. So this is a very important conclusion when the test we have, when the report we receive is going to follow our patient. We are going to receive a report, and we must look if this report is standardized in the international scale. So the international scale is not the only way to measure, and there are some obstacles and potential solutions in developing countries. Now, each strategy has distinct pros and cons, as you can see. And here we can see the homebrew assay, the semi-automated assay, and the shipping to specialized centers. So the homebrew assay, the process that is optimized to specific laboratory needs, as I have said, locally sensitive and reproducible. The cons, that's highly technical training, very expensive machine and reagents, and often performs worse at new locations. In the middle, we have the semi-automated assays that perhaps are one interesting assay and in low-income countries, but the reagents are self-contained, and this is less technically trained needed. So you don't need a specialist, and anyone can do it. This is quick, but what are the cons? They are very expensive, the cartridges, to buy them and to maintain. And then the other one is the shipping to specialized centers. That is a very good option because you send the sample in 24 hours to the specialized center, but the shipping is expensive sometimes, and the samples not always arrive in the optimal way because they have to arrive in 24 hours. So this is a cons. So changing to the mutational analysis, it's important to mention that in chronic phase diagnosis, it has not clinical utility, but yes, it's recommended to perform in accelerated phase or blast crisis. So here I have a clinical case that I would like to mention about a female of 65 years old that has been diagnosed in 2009 and with CML. There you can see the blood count, the hemoglobin and the platelets. The blood count are high, the platelets are very high also, and the patient has anemia. This is a high-risk Stockholm score, and the patient started with nilotinib. So here we can see if we have done the things correctly. The patient has a complete blood count, a physical examination with splenomegaly, chromosome binding analysis that makes the diagnosis of CML because the presence of the Phi chromosome on 100% of the metaphysis is present, and the aspirate of bone marrow. But the doctor who diagnosed this patient didn't have the opportunity to make a qualitative PCR, but he performed a quantitative PCR. So the quantitative PCR showed 0.8% of BCR-ABL in a non-standardized lab. So what about this? This is a quantitative value, a very, very low quantitative value in a non-standardized lab at diagnosis. So what we can do with this? So the recommendation is to repeat it or to think perhaps this is a laboratory error. And what it's also recommended is to make the qualitative PCR revert transcriptase polymerase chain reaction for the detection of the transcripts and identification of the transcript type. To detect the BCR-ABL variants of P190 or 330. So this is important to take into account because with the qualitative PCR, we're going to know the transcript type, if it's present or if it's absent. So the patient repeated, but this time a qualitative PCR, and the qualitative PCR showed that the protein P210 with the B2A2 isoform was positive. So we had a transcript, a common transcript to 10, and we have the confirmation of a CML. We had the confirmation previously with the cytogenetic, obviously. Huh? So what happens? What happens at month 3? At month 3, the patient performed because the doctor told him that it was very important as prognostic marker to make a month 3 test, a qPCR. So a very deep molecular response was defined, MR 4.0. But I want to clarify that in the report, no copies of gene control were informed. So this is the definition of cross in leukemia, and also what ELN included in the last guideline recommendation. And it's the definition of what we need to have in the report to trust that that test. So as an example of this case, we're going to look for MR 5.0, and MR 5.0, the very deep molecular response, has a ratio of less than 0.001% of BCR-ABL in the international scale. And this must be performed over 100,000 copies of ABL if we are using ABL as control gene. So in our study, we didn't have that information. So here I wanted to put a real life situation where we can see that this is very important, because we are talking about diagnosis or month 3, and then we go to the end of the story that it's TFR. But if we don't have this clarified, we will never select that patient for discontinuation. So we need to continue with education in the international scale, in this case in Latin America. So in this report, we can see that the response says more than 5 logs. But it doesn't say that it's standardized in the international scale, and it doesn't talk about the number of copies of the gene control. So the BCR-ABL transcript level is not expressed in international scale, so it is not standardized, and we cannot monitor this patient, for example, for TFR. So what must we do? This is another report that it's like the opposite, because this includes the report says, for example, the patient has indetectable transcript MR 5.0. And here we can see that the international scale is named, and that the number of copies of BCR-ABL also is reported. So this is very important when we are going to select the patient for TFR. So the purpose of increasing the reproducibility of the analysis and between methods, allowing the clinicians to determine the significance of a change in BCR transcript level, is one of the most important things that the international scale molecular monitoring has as a pro. Also, access to the international scale has improved, but this remains a challenge in low-income countries, as I have given an example recently. If the lab is not aligned in international scale, the possibility of interlaboratory variations continues to be an issue, and non-optimal monitoring is worse than lack of monitoring. because this may trigger inappropriate clinical decisions or delay clinical interventions. So with this, I finalize my presentation saying that it's very important the interaction between bench to bedside, that it's the lab and the doctors with that are hematologists, and the interaction with our colleagues on the lab. So continuous connection between clinicians and laboratory staffs as a useful tool for optimal outcome in CML patients. This is very, very important. So we must work all together for the benefit of the patients. Thank you very much.